And this group looked at 7 patients who developed secondary AML from MDS. And in these 7 patients, they performed deep sequencing, whole genome sequencing, of skin samples and bone marrow samples in order to identify those mutations that were specific to the leukemic cells of the patient. And then they went back and genotyped bone marrow samples that had been obtained during the antecedent MDS stage of the disease to determine the presence or absence of those specific mutations. And using the allele burden of hundreds of different mutations, they were able to define the clonal architecture in the paired samples from the MDS stage and the secondary AML stage. And this panel just depicts a particular example of a particular patient, but overall, they observed that the genetic evolution of secondary AML from MDS is a very dynamic process, which is shaped by multiple cycles of mutation acquisition and clonal selection. And in every case, progression to acute leukemia was defined by the persistence of an antecedent founding clone containing hundreds of somatic mutations, and also by the outgrowth or emergence of at least one subclone harboring dozens to hundreds of new mutations. All founding clones and subclones contain at least one mutation in a coding gene. And the authors interpreted their finding that the dominant secondary AML clone was derived from an MDS founding clone in all cases, suggesting that therapies targeted to these early mutations might be the most effective strategy for eliminating disease-propagating cells. Now, ladies and gentlemen, I think that these new mutations will help us to gain new insights into the pathophysiology of MDS. But I also believe that these new insights, that it will take years, many years, until these new insights will translate into novel treatment options. So for the time being, we have to employ all the existing treatment options in an optimal way to alleviate the clinical problems that plague our MDS patients. And the most common clinical problem in MDS is anemia. And data from the Düsseldorf MDS registry show that anemia is an initial symptom in 85% of MDS patients. And the prognostic relevance of the degree of anemia in patients with MDS has recently been re-evaluated in a joint study by the Pavia and Düsseldorf working groups. And as you can see here, the probability of non-leukemic death, mainly from cardiac complications, increases dramatically in male patients with a hemoglobin of less than 9 and female patients with a hemoglobin of less than 8. So an important message seems to be that you should take care of your MDS patients and transfuse them adequately to keep their hemoglobin levels at least above those critical thresholds. However, this may come at a cost, because the proper amelioration of anemia will almost certainly increase the likelihood of survival. But on the other hand, the concomitant development of iron overload, of transfusional iron overload, may have an opposite effect on overall survival. Now, as far as iron overload is concerned, I should like to cite this gentleman, Paracelsus, a Swiss Renaissance physician, philosopher, astrologer, botanist, alchemist, who is sometimes called father of toxicology, who famously stated that all things are poison, and nothing is without poison. Only the dose permits something not to be poisonous. Or in short, the dose makes the poison. And this is, of course, also true for iron. On the one hand, iron is essential because it is needed for a great variety of pivotal biological processes. On the other hand, iron can be toxic. because it greatly catalyzes biochemical reactions that generate oxygen radicals. And those reactive oxygen species are the culprits. They are the offenders. They attack macromolecules and organelles, thereby creating cellular dysfunction, cellular damage, which ultimately leads to organ dysfunction. And this potential of iron toxicity is, of course, increased, is exaggerated by iron overload. And interestingly, iron overload in MDS patients starts before the patients are started on transfusion therapy. And this is because in MDS, as well as in thalassemia, there is ineffective erythropoiesis. And ineffective erythropoiesis sends out a signal to the gut to absorb more iron. And this is mediated via suppression of hepcidin in the liver. Hepcidin normally downregulates duodenal iron absorption. And if hepcidin is suppressed, then there is unrestrained intestinal iron uptake every day, which will finally add up to iron overload. For many decades, it has remained mysterious what this signal from the bone marrow is. But in thalassemia major, the problem or the riddle seems to have been solved. There are massively increased levels of GDF15, growth development factor 15, which suppress hepcidin expression in the liver. In MDS, GDF15 levels are also elevated, but not nearly as much as in thalassemia. So other factors seem to be involved as well, and one of them is TWSG1, that's twisted gastrulation-like protein 1. Now, hepcidin is the central regulator of iron metabolism, and there is certainly dysregulation of hepcidin in MDS patients. And this dysregulation of hepcidin in MDS is a bit complicated and heterogeneous. On the one hand, there is the influence of increased iron stores, mainly from transfusional iron overload. And increased iron stores stimulate hepcidin production in order to decrease duodenal iron absorption. And this physiological response tends to be conserved in patients with RA, 5q- syndrome, and RARS. But this response appears to be relatively blunted, as indicated by a relatively low hepcidin-ferritin ratio. Why should this physiological response be blunted? Well, because there are strong opposing forces, like ineffective erythropoiesis, anemia, increased EPO levels, which all decrease hepcidin production because in all these conditions, there's a greater demand of iron in the bone marrow. And then we have patients with CMML and RAEB. In these patients, the situation is confounded by inflammation, by inflammatory cytokines like IL-6, which is known to strongly stimulate hepcidin production. So there are many factors, and in different types of MDS, the relative weight of these factors differs. So in different types of MDS, we have different mean hepcidin levels. Hepcidin levels are relatively high in CML and rape patients, and they are relatively low in patients with RARS because of a strong influence of ineffective erythropoiesis. Well, the hepcidin story is important in order to explain why patients develop iron overload before they are on transfusion therapy. But this increased duodenal iron uptake certainly contributes to iron overload, but it's not the main cause. And this is shown by looking at serum ferritin levels at the time of diagnosis when patients have not yet started transfusion therapy. And at that time, it is rare to see serum ferritin levels above 1,000. Patients usually have a serum ferritin level of, say, 400 nanogram per milliliter. And this is not particularly frightening. clearly the most important cause of iron overload in MDS is transfusion therapy. Consider a patient who has a relatively high transfusion requirement of 4 units per month, which is not extraordinary. This patient will receive about 100 units of red cells over 2 years. And 100 units of packed red cells is equivalent to at least 20 grams of iron, because every unit of packed red cells contains 200 to 250 milligrams of iron.